All right, good morning and good afternoon, everyone. My name is Michael Martin. I'm with Comagine Health. I am the Nevada Hospital Improvement Innovation Network hospital liaison. I'd like to thank you for attending our event today. Today we are presenting the Reducing Readmissions Town Hall with Penn Medicine Lancaster General Health. We just want to go over a couple house rules with using Zoom. This image here will show you basically where everything is located. Most of you have already found the chat box, which we're going to use the chat box to answer any question, or actually have you ask any questions for our presenter. What we'll do is we'll read those towards the end. So as the presentation moves along, if you have a question that pops up, we ask that you don't just chime in right then and there. Please just go ahead and ask the question in the chat box. We will review all questions at the end of the presentation. Towards the left, you have the mute, unmute. We will unmute the lines at the very end after the presentation's over. And then we'll just start filtering questions, any questions that you may have through that. If you feel brave enough, if you'd like to share your video, the button right next to that, you'll be able to do that. And if you're joining by phone, to mute or unmute yourself, it's just press *6. You won't be able to use the chat function, unfortunately. So if you are just using dial-in phone, please just unmute towards the end after the presentation's over, and then we can get your question answered as well. So I think that's it for Zoom. This is just a quick overview of what we plan on sharing today. Just take a look at that and make notes. With that, I am going to turn it over to our presenter, Dr. Ripchinsky. He's the Chief Clinical Officer at Penn Medicine, Lancaster General. Dr. Ripchinsky, are you there?
Hi, yeah, good afternoon.
Perfect. I'm going to stop sharing my screen so you can take over.
Okay, great.
Perfect, looking good. It's all yours.
Awesome. So hello, everyone. Thanks for joining. I am certainly, as part of a disclaimer, responsible for being the voice for this work, but by no means have I been involved in all the efforts. So I'm happy to be able to share with all of you some of our journey, which goes back several years in terms of focusing in on readmissions and our efforts to improve them across our health system. Just by a short introduction of myself, I'm family physician by training. I actually have been in the role of a chief clinical officer for about 15, 16 months. Before that, spent about 4 years as the quality officer, and before that, about a decade as the chief medical information officer here at Lancaster. We're about a $1 billion health system inside of Penn Medicine. We're in South Central Pennsylvania, about an hour west of Philadelphia. We have our main hospital's been in this community for 126 years now. And we are essentially about 35,000 discharges, 120,000 visits in the emergency department. And that just gives you a sense of our size and scope. We're over 1 million outpatient visits here in a year. So certainly can take any other questions about us too later in the presentation. So let's get right into it. I thought what I'd do is divide up our conversation today into 3 parts. One part being around strategy and governance, because I think it's effective for us to create a structure in order to enable success. And I want to tell you a little bit about how we've done that from a governance perspective. Second piece is really talking about operational critical success factors. I think a lot of you are probably trying to implement changes and improvements to your readmission rates. And hopefully I have some pearls and nuggets in that second section. And then finally, I thought, well, we maybe look at a few use cases in terms of disease types and some of the things we've done in certain diseases to try to address our readmission rates. So first thing, we are on the journey to be a high reliability organization, and we're basing that journey on the Institute for Healthcare Improvements framework for safe and reliable care. We started a operating model based on a lean management system. Lean is a daily management system, and that effectively is our learning system. We started that in 2016 and have trained over 11,000 staff, physicians, members of the health system. In addition to training, we also have had 350 huddle boards implemented from across the organization, both in the physician practices, our ambulatory sites, as well as inside the hospital. So even though we've started that learning system, we've recognized the importance of also co-developing and or simultaneously developing a culture of safety, and that is predicated upon the psychological safety and really improving our efforts to reduce hierarchy, especially in the surgical operating rooms and the procedural areas. And most notably, we started a journey in this actually in the last few months around creating a just culture and a workplace accountability structure. Here based on David Marks's work and outcome ingenuity. But those two pieces of the framework on this slide, the learning system and the culture, are really united by the leadership keystone piece. And for us, we spent a lot of time developing our management team of 400 leaders with all the skill sets inside this framework. And I recognize this, both the quality officer and chief clinical officer, that we have a lot of opportunity still to engage patients and families, not only on this readmission conversation, but in quality and safety as well, so that we're still developing our efforts around furthering our engagement of our patients and families in the journey. So one of the things we do is we work from a strategic framework, what we call the blueprint for quality and safety across Penn Medicine. And those imperatives are based on three on the left there: engagement, continuity, and value. Not surprisingly, the goals that we line up to in Lancaster are very much tied to probably all the things all of you are working on, whether it be likely to recommend. You can see our 30-day readmission rate gets top billing for our quality and safety goals. We continue to improve access to care. And on the three at the bottom there, you can see we're working on our mortality index as benchmarked in Vizient. We have a continued focus on reducing healthcare-associated infections. And as I am a family physician, I can't not have improving our cancer and depression screening rates and vaccinations, of course, what's affecting our ACO as well. Here's a little bit of how the work gets done. And I mentioned this is probably one of our biggest improvements over the last 20 years to align ourselves to enable the work to happen, especially around readmissions. So as you can see on this slide, we have a local board of trustees, the community members. We have a quality committee that's a third community members and board members, a third physicians, and a third administrators. And that quality committee has really deep knowledge of some of the work that we're doing, both on the opportunities to improve, like patient safety events, but also on our success around enabling our staff to come together to reduce those readmissions. The real key to the puzzle for us are at the bottom half of this slide. We have our service line clinical effectiveness committees, and we align ourselves and our performance improvement and quality structures around those service lines. So each of those boxes on the bottom left actually have a physician partnered or dyaded with an administrative service line leader. And those two, sometimes as a triad as well, with a nursing leader in the area, effectively function not only for typical service line metrics like growth and access, but very much tied to improving quality and patient safety across the service line, so into operations, whether it be the practices or in the hospital. And you can see on the right, we reflect basically the same structure, a performance improvement structure, whether it be in departments or sort of areas that are more cross-functional, like trauma, critical care, and the hospitalist committee. They're the ones, as I'll go into later, are really doing the heavy lifting for the analysis and improvements of processes to reduce the readmits. I'm not going to go through all this slide, but I will say in this strategy and governance section, it's so critical for us to be well aligned with resources in our community, and that I think has been a success factor for us. We've had a long history, in fact, over 50 years. We just celebrated our 50th anniversary for the family practice residency here in Lancaster, one of the first in the country, actually. And that, as a result of having that strong family medicine training here, a lot of the family docs who have trained have stayed, and as a result are in the community taking care of our patients. So it really serves as a real strong foundation catch them, if you will, after discharge and ensure that they have the things that they need to prevent a return to the hospital. But equally as important is sort of the wrappers that you can see at the bottom of this cake, if you will, in terms of community resources, whether it be with clinics in the area, or whether it be with pharmacy programs, social services that we connect patients to. All of those are critical to our success. We created a skilled nursing facility preferred network as well, which I'm going to talk about, and I think that that's also been important for our success as well. So let's get right into it a little bit, and let me explain a few of the things that we did, actually going back to, I would say, 2015 or 2016 or so. We recognized that despite us having, if you will, decentralized model of having each of those service line leaders begin to look at readmissions cases and things like that, we never had one place where we could sort of cross-functionally talk about readmission themes that go across different patient types. So to carry that out, for instance, we had the heart and vascular service line group looking at heart failure readmission rates. But what we weren't really doing was talking about, well, what are the heart failure patients and the COPD patients and the pneumonia patients and the renal failure patients, what factors would they have in common for us to maybe put system-wide programs in place that could prevent readmissions. So in an effort to try to address that issue, we created a multidisciplinary committee, Readmission Committee, aptly named, which had physicians, nurses, ancillary disciplines engaged, depending upon the topic that we were talking about. And we did very deep focused chart reviews on gosh, over 1,000 7-day readmits, and have done probably more than 1,000 now, 30-day readmits. The actions of this committee is really, after those structured chart reviews, we created a review form, if you will, in MIDAS, our quality system, such that we could capture some more discrete buckets on, the real clinical why they were readmitted, not just, were they readmitted with the same diagnosis, and not just leveraging administrative data like we typically do, but really try to capture and bucket the, social barrier that we had to mitigate, or the clinical opportunity that we have to fix. And then even further tying it to our peer review structure, if we saw an opportunity to improve at a peer physician level, we would refer out of this committee to peer review and process it through our normal med staff structure. So having that structured analysis with structured questions enabled us to really get good data to develop those early action plans. And then because this committee was, broad facing, let's say, and only met, at the most frequent time, maybe once a month, we recognized that we had to sort of, if you will, launch out an action plan from this committee, and we sent it back to those clinical effectiveness teams. Those were those blue boxes on the previous slide for governance, the service line level committees. And so the clinical effectiveness teams that could then be responsible for sort of carrying out potential process change. So I mentioned we looked at over 1,000 cases, and I guess this was data going back to 2017 or so. And like the literature showed, we were essentially the same. 4 days average to readmit, and about a quarter of them were avoidable. And of course, we could judge that at the top level, but until we asked the physicians and clinicians and nurses to really look at these charts and say, well, what was the avoidable reason? I don't think it would have been great data. So the beauty was we could now sort of sub-bucket into, okay, well, that was avoidable because we discharged them early, or that was avoidable because we didn't have them follow up in 7 days in the PCP's office, or that was avoidable because they couldn't refill their medications, or they didn't have insurance coverage. All of you who are working on readmissions, all of these. But it just really, having this structure allowed us to, I think, create the performance of, okay, well, we need to actually improve that. So what kind of systems and programs can we put in place to do that? You can see here too, we also had a pretty decent 7-day return rate from the skilled nursing facilities. And so that was a critical piece for us, because around the time, let's see, going back about 6 years, we started in the Medicare Shared Savings Program. And when we looked at the claims data in the early days, we realized that there was a lot of our spend and both spend and readmits were coming from our skilled nursing facilities in the sort of South Central PA area that we work with. If any of you know about Pennsylvania, it's certainly a high area to retire. In fact, USA Today actually ranked Lancaster one of the #1 places to retire a couple of years ago. So it's certainly, we certainly have our opportunities to work with those skilled nursing facilities in the community. So another thing we were able to do, because we had discrete data, and we were able to bucket some of the opportunities just by volume, by DRG. So you can kind of see here, not surprisingly, sepsis and heart failure are leading the way with total volumes in this analysis we did back in 2018. And this was probably, this was about a year's worth of cases that we were kind of looking back on. Problem is, when you get to the DRG level, depending upon whether you take it to individual DRGs, it kind of loses its meaning, which is why we supplemented kind of the administrative analysis with this clinical chart review, which I think was necessary, because heart failure patients and sepsis patients almost had a relationship together, because as you can imagine, sepsis patients get a lot of fluid, and as a result, they all sometimes come back as a sepsis patient, but oftentimes they come back as a heart failure patient. So we had to sort of think differently about how to, treat both of these sets of diagnoses early on. I alluded to our journey with the Medicare Shared Savings Program back about 6 years ago, and at the same time, we recognized that we needed to really develop Level 3 NCQA accredited medical homes across our primary care sites. So while we had great primary care physicians, and they came out of training in our residency for the most part, we didn't have really, despite having a common electronic health record at that time for Epic, we didn't really have a common way of, this is how we do it here in primary care. And I would say that the guiding principles and guidelines for that medical home accreditation from NCQA, it really drove us to set up what you can see on this slide, which was enabling the electronic health record to empanel attributed populations to providers. So we could really divide up, okay, who's the primary care physician? How many patients do they have on their panel? And then we actually took it a step further with initially a homegrown risk stratification tool, but supplemented it later with claims data using Johns Hopkins ACG model to try to risk stratify those populations and subsegment them into what do they need, whether it be medical care or social services support. We expanded the care team roles and really changed, what does a medical assistant do? What does a nurse do? And at the same time, we were expanding those care team roles. We were undergoing the, if you will, lean management PDCA cycles of saying, okay, where's waste? Where can we eliminate it? And where can we add value-oriented care? There's a big piece around wraparound services. So I'm going to get into our comprehensive care management model and how we change that in a future slide, but that's critical. We've rolled out integrated behavioral health counselors to every single one of our primary care sites. I think that's really been huge, given the both mental health opportunities with physical disease that exists in our population. So let's talk about our redesigned care management. First off, we made a transition, oh gosh, that's probably going on 6-7 years now as well. Our inpatient case managers previous to this switch were very much unit oriented in the hospital. So one case manager equals to one unit. And what we thought about doing, and it's very similar to the time where we made that layered cake slide that I showed you at the beginning, we recognize that, okay, well, we have all this well-connected, come to your medical home, and these are the team members in your medical home. Well, why wouldn't we just connect the inpatient case manager with that concept? So we redesigned the case management team to be oriented to our PCP practices, both our employed groups and our independent groups in the community. So that really enabled us to ensure that, okay, that case manager can now be the intermediary from the hospitalist or the intensivist and the hospitalist, and hand them off to the PCP. And sort of, it really has enabled us to get feedback from the PCPs of what do they need, and that's improved our discharge summary and our handoff tools. And it's also helped inform, the PCPs of, okay, here's the data from the hospital in return. So that's been, I think, a real positive change for us. The other thing, and many of you are probably doing this, we're creating the ambulatory collaborative care team. It's a multidisciplinary team RN, social worker, pharmacist, community health workers that essentially sit in different regions where our primary care sites are located. And because they're more regionally focused, they can focus on those patients that are at the top of the risk stratification. And you've seen the sort of description of, the top 1% of the population, using 50% of the spend. I'm not quite talking about those top 1%ers for this team. This team more focuses on the 2 to 5% in the population that have either rising risk or, are high risk but not super high utilizers or super high spend. So they enable both the care and the connections with community services and addressing any barriers with the patient and working alongside either home care nurses and or our PCP practices. Our super utilizer clinic is Care Connections, so they're serving the top 1% of our patients, and they go a step further with linking up legal, counseling, in-home visits. It's very high intensive, high touch care. As exists really across the country. We didn't do anything special about that program other than enable the resources and free them up to take them into the program. And we've graduated probably over 500 patients now through that program over the last couple of years, back to the PCP medical home. And oftentimes they have the wraparound ambulatory collaborative care team helping them as well. Skilled nursing facilities, I indicated earlier, big piece of the puzzle for us. We actually partnered with 9 of them to create a preferred network. And inside that preferred network, we kind of agreed to, hey, let's work together on reducing readmissions, length of stay, improving outcomes. Most importantly, I think we work with them to create care plan documents, like what happens if the patient decompensates after they get discharged to you. And they do decompensate. How do you handle that? And who do you call? And how can we help prevent that you from just sending them back to the emergency room? So by doing that, we were able to reduce readmission rates, you can see at the bottom of this slide, to about 8.5%, which actually is much lower for us. Our overall system rate right now, we calculate internally, either in MIDAS or Vizient as benchmarked, roughly around 10% now in our 30-day readmits. Other big operational success, I mentioned our Epic electronic health record, and when we empaneled the providers and we risk stratified them, we also were able to create work lists, if you will, such that nurses in the office could see, okay, who was about to be discharged or who just was discharged. And we can prioritize that by the LACE score, the risk for readmission, looking at day of discharge and what was their admission type. A long story short, this enables us to coordinate outreach, and you can see some of our outreach results at the bottom. This is for our entire medical group over last year. We ran these data and essentially contacted in 2 days of discharge about 84%, and appointments scheduled in about 75%. Now, of course, we're a little bit lower on the appointments actually completed within the 7 days, because oftentimes we might have the in that number as well, and then they might just go see the surgeon and they're not at high risk for discharge. Just high risk for readmission. Here's an example of that work list that we use. You can see, LACE score in here. We actually added Coumadin, sort of high risk med look. You can see PCP visits, when the last one was, when the next one is. You can sort of see if they were discharged to rehab or a skilled nursing home, so the nurse in the office wouldn't call them if they weren't necessarily discharged home. And then you can kind of see when we've done TOC as our transition of care outreach dates and times. And then you can obviously see PCP there and the elements of the LACE score individually at the far right. We did a transition of care documentation. So this enabled a standard method, just like we've done for medical homes. We have now a standard method to handle that sort of this is what happens when we're on the phone with you, and we're going to go through that. And then we carry that through into the office visit. I thought I'd wrap up with another 5 or 6 minutes or so on some case examples. This is data right off of CMS's current hospital compare site. You can see we're better than the national rate for readmits on heart failure right now. We're about one of 120 hospitals in the country that are better than that rate, and one of 7 in Pennsylvania. Pretty proud of this work, so let me tell you a little bit about how we do it. We geographically try to aggregate the inpatients with heart failure. Easier said than done. We do have 1 heart failure unit, but oftentimes our hospitalists are running all around the hospital still caring for those patients. So we recognized, actually dropping down to the third and fourth bullets, the importance of a nurse navigator to try to coordinate some of the education and care when the patients can't be geographically aggregated. So we're still working on that one, but I think we have some good early learnings. We worked a lot on patients getting readmitted with chest pain. You know, what's normal chest pain? What's concerning chest pain? How does the ambulatory collaborative care team help assess those patients in the outpatient space to prevent them from just boomeranging back to the ER? The community-based paramedic has also helped with that. We've probably put about 50 or 60 patients through our community-based paramedic program. It's a relatively new ad for us, but we want to see if that has sort of a different approach to care than what we've had with our nurses in the ambulatory collaborative care team. So we're trialing that now. One of the biggest pieces of our success of those low rates that I showed you on the previous slide was our heart failure clinic, which is managed by our cardiologists, and they have sort of this open access approach run by nurse practitioners, and we continue to revise and update that clinic. So we continue to work on that. We do a lot of palliative care conversations too in the community, and I think that that's a critical success factor. A little bit on oncology. We're participating in CMS's oncology care model. So obviously, we're basically bundled payments for medical chemo patients. So reducing readmissions is a big piece of the puzzle. And what was nice was because we had already built the medical home and all those processes I just shared with you in Epic, we just basically took that and gave it to the oncologists, and they're implementing some of the same tools. But one of their big pieces is around symptom management, to recognize, you know, if a patient's getting dehydrated, how do you handle that? And actually, the way, this is kind of a creative method, they use our lean management daily huddle boards, where the oncology nurses actually sort of tasted the actual hydration methods that they often recommend to patients, and then they created their own preference data to say, why were we ever recommending these other ones? They taste terrible. So they really tried to come up with a creative way to tell the patients, okay, these are the best tasting hydration methods, so that you don't have to necessarily go to urgent care or come to the ER for hydration, but instead you might be able to handle it at home. And so they were very creative on using some management techniques to essentially get to that point where they could teach the patients about that. I don't have great CMS publicly available data yet on readmissions for OCM. They don't put that out, but one of the figures I included here was in our recent OCM package from the very, I guess, beginning of some of our work, showing our practice in blue in terms of admission rates to acute care. So you figure you're gonna have low admission rates, you're gonna have low readmission rates. So this kind of shows you where we were in blue versus some of the OCM practices in the country, and all practices providing cancer care in orange and green respectively above. Orthopedics was another area. We actually had a readmission penalty for orthopedics several years ago, and so we ended up taking on a sort of orthopedic ownership of those readmissions and trying to create some standard processes. We really looked at anticoagulation guidelines and wound management. So infections and DVT-PE were some of the biggest causes of why we had the readmit penalty. So after we put some changes in place, and we also incented the independent doctors with the bundled care model in 2014, doing BPCI really engaged them in the process to prevent readmits. And as well as we have a perioperative surgical home, which I can go more into during the Q&A if needed. But there have been sort of critical pieces for us to essentially lower our readmission rates for hip and knee replacement patients. And you can see the trend over time for us, and they've continued to be this low, and we've been able to avoid the penalty for the last 3 years. Finally, I wanted to wrap up on advanced care planning. I alluded to it earlier, and I think it's a really big piece for us because in the 7-day readmits, we had many patients who, families were on different places on the journey of, okay, should mom or dad be a DNR? What's their advanced care plan? Do they even have one? How do I get one? And we really tried to grow those advanced directive documents that we store in Epic. Pulse are the physician orders for life-sustaining treatment in Pennsylvania, and they also have been growing. We've trained 175 facilitators to have the conversation based on Gunderson's Respecting Choices model. So this has also been a critical piece for us because oftentimes, you know, we were seeing a cohort of patients constantly get readmitted because nobody wanted to have the hard conversation about, well, mom or dad is, you know, slowly dying from heart failure, and this is what we will continue to do, i.e. readmit, unless we take a different plan. And having a really strong hospice and community care, actually the largest in Pennsylvania in our community, has really been helpful for us to really reshape some of these conversations for our patients and their families. So hopefully that got your appetite whet for some questions. I'd rather enjoy a conversation about some of the things we're doing. Happy to take questions, but you can see in summary that I don't think we would have been successful unless we really set up a strategy around high reliability, and I created a governance structure on quality and safety to try to drive those operational success factors. And engaging those multidisciplinary teams, I think, has been critical to our success, because then we were able to staff them with, you know, electronic health record changes, analysis tools, as well as, you know, process change and process improvement coaches to help really continue them to drive their work, be able to measure it, and make changes if they need to. So hopefully, Michael, you got some questions. I think I'm switching it back to you, right?
Yeah, I'll go ahead and take over from here.
Great.
All right. So far we just have one question in the chat. If you have a question, if you feel more comfortable just typing it in and then we can ask the question, please feel free to do that. I could just read the question for you. Let me just pull up the chat box 1 second, sorry. All right, so the first question we had was from Joyce. Would you be willing to share the chart review tool?
Yeah, sure, absolutely. I mean, it wasn't rocket science. A lot of it was, we started to build the questions based on things that we've learned, like looking at the charts. We started at a question of, okay, well, if we wanted them to follow up with the primary care physician, which primary care physician did they follow up with? And did they actually have an appointment? Did they make the appointment? Those were kind of some of the initial questions. If they went to rehab or they went to a skilled nursing facility, which place did they go to? But then what happened to them when they got out? Did they have an appointment? Did they follow up with that appointment? I might be able to, if on the fly here, be able to bring up the tool too, and I can show you live if we end up switching screens back.
Yeah, I'll stop sharing for a second so you could pull that up. Just let me know when you have it and then we'll go from there.
Yep, sure. I can take another one.
Okay, Seema, I believe Seema had a question. If you just want to unmute yourself.
Yes, I have few questions. Question number 1, how is your organization supporting social workers, pharmacists, and community health workers when it comes to the billing?
Yeah, we're just paying for it because we recognize this is the right thing to do for the community. You're right. We don't have any creative models, although I will say, and I didn't really go into the detail, we have a accountable care organization which houses our Medicare Shared Savings Program as well as our commercial contracts with payers. And in those commercial contracts, for instance, we're negotiating care coordination fees.
I see.
And we're about to become an NCQA certified, you know, ACO, if you will. And once that happens, I think the flow of care coordination fees from the payer directly to us will essentially help fund some of those things that we've been funding year to date.
That I see. That's like a huge barrier, especially in a mid-sized practice.
Yeah.
Other questions I have is, how do you manage your patients, those who are in skilled nursing homes?
Really good question. So, as a part of the preferred provider network, we actually created 2 post-acute care manager positions. And they globally use a piece of software called Real-Time, which gets feeds from the individual nursing homes, EMRs. And they're able to check, if you will, care gaps. Are the patients following the care plan? And be able to almost like check for variance. So those 2 care managers are kind of in touch with the directors of nursing at the skilled nursing facilities. While they don't do day-to-day case management of individual patients, they do look to coordinate programs. So for instance, they would be responsible for working with the skilled nursing facility on, hey, this is our sepsis care management plan. hey, this is our heart failure care management plan. Hey,
Mhm.
this is our pneumonia care management plan. This is our hip fracture care management plan. We've done 5 or 6 of them now.
I
And
see.
so they're responsible for teaching this, the SNF and making sure that sort of our agreed upon care plan, because you're
Uh-huh.
in this preferred network with us, we make sure that the agreed upon care plan's carried out, and there's measures to ensure that the care plan's being followed. So they're
But
kind of coordinating almost like air traffic control rather
right.
than individual care of patients at the nursing homes.
Okay. And are providers responsible? Like, how does that part works? Who are these?
Yes.
Who
Thank
are?
you.
Yeah.
Yeah, good question. So one other critical piece of our puzzle, because we've had a lot of great family docs, and I mentioned the 50-year history of family medicine, some of those family docs have actually turned into geriatricians.
Right.
And now, as a result of having great geriatricians in the community, we almost have, actually, we have a employed geriatrician as the medical director at every one of the preferred provider network skilled nursing facilities.
So if these managers have any questions, they are reaching
Yes,
out to the
right.
director of that.
Yes,
I see.
yeah,
And I don't want to take over this conversation, but I have 2 other questions.
yeah.
In your outpatient setting, are you doing CCM, and have you seen any changes in admission rate? Chronic care management.
Yeah, we are not really doing that too
Okay.
well. And I would say more the driver of the readmission rates are some of the things I told you about, like our medical home and the preferred provider network skilled nursing facility work, other than CM driving it.
Okay.
Yeah.
Okay. Yeah, thank you.
And Michael, I have, I think I removed all the PHI from this one. If you want to send me back the screen, I can show our Midas tool.
Go ahead and take over whenever you're ready.
Okay. I think you can see my Word document now, right?
Yeah, we can.
Okay, so just to lay it out, I don't know if I can go.
Maybe on the bottom, you might be able to make it a little larger.
Yeah, that's what I was thinking. I was thinking maybe I could just do full page or something like that. Let me just zoom in. So what we essentially did here, and get rid of my chat. There we go. Put you guys to the side. It's a pretty basic tool, right? I mean, it's got diagnosis, potentially avoidable, premature discharge. You're probably all taking screenshots, which is good. Failure to, receive instructions. Was there a diagnostic or therapeutic error? You can see this kind of stuff just doesn't come from, a simple, let's look at coded data and see what happens. And these questions also expand. So let me think. I don't want to show you my full screen that I'm looking at it because it has PHI on the top. But let's give, on the SNF one, discharge. No, let me think. Well, let's leave the palliative care one. So is the prognosis less than 6 months? If you say yes, it actually says the next question, it cascades and opens up. If the prognosis is less than 6 months, was there palliative care input? So see, it kind of just has a cascading effect to it. If we say no, why no or why yes, so we can kind of get some additional data. They all don't cascade. It's only a few of those at the bottom that do cascade, and maybe 2 at the top. Like if there was a complication from initial discharge and you say yes, a free text box opens below so you can explain it. Same thing with if there was inaccurate or AVS education and you say yes, well, we want to know, what did you mean? So we actually ask them to type something. And then on the bottom of it is, okay, in the physician or clinician's words that reviewed the case, what were the real issues? Did they just totally not take the meds? Did they not pick up the meds? Did they not understand the meds? Was it a health literacy issue? Was there a social barrier? So it really allows us, even though it's more free text at the bottom now, it allows us to get that granularity that we wouldn't typically get from just kind of looking at, here's the coded data. So hopefully that was helpful.
I do have a chat from Sharon. She asked, did you use standardized or already made focus studies in Midas when you did your retrospective chart review, or did you make your own?
Yep, made our own, and I just showed it to you.
Okay.
So that was hopefully that was obvious. But yeah, we basically used a focus study and created our own template with those questions I just showed.
Okay, perfect. Does anybody else want to chime in, ask a question? That would be the time. I'm going to sneak one in real quick.
Okay.
Just in regards to patient engagement, I'm curious, has your organization developed like a patient family advisory council to help
Yeah, we
kind
need
of,
to.
okay, so that's something that you still,
Yeah, we have one, but I would say in a true high reliability organization, we have some opportunities to improve not only the questions we ask, but the frequency we meet
okay,
and the input that we gather. So we've tried it. It needs an overhaul.
okay. Is it kind of, right now, is it kind of just treated as maybe like a focus group?
Yeah, it's a little bit
As,
more around patient experience and not necessarily around performance improvement, quality, safety topics.
okay. And then just another quick question. Do you use like a state's health information exchange when monitoring patients to
Good
help
question.
follow or grab
Yeah,
information?
yeah, really good question. So luckily, and unfortunately, it's probably hard to apply to some of your areas, we're about 70% market share in terms of inpatient. So we kind of already know those that leave here most often come back here, and those that leave here kind of go into our primary care community and we can follow them. But our primary care docs probably only care for 40–45% of those discharges. So we have created relationships with the independent doctors in the community. We send them our transition to care reports. So we have ways to do that with Epicare Link. And they're able to see like, okay, these patients are getting discharged and they're coming back to us, and these are the data that we need to make sure that they have a good handoff. The other thing, we are an HIE for Central PA, and we do have a couple independent docs giving us data, but I would say the other health systems in our region, both Central PA and then towards Philadelphia, we're pretty much all Epic shops now. So using Care Everywhere really enables us to see almost everything.
Okay, great, thank you. Any other questions? Once again, if you're a little bit shy about asking, please feel free to just type it in. If not, just speak freely.
I can ask one question. How are you dealing with certain populations? Social determinants is a big thing now. Certain
Right.
population. What's the
Yeah, we can't win them all or get them all at the same time. So our board's decided to prioritize, and one will come probably not as a surprise, and one may come as a surprise. One of the first things we're doing is, like others in the country, we're focusing on food pharmacies. And because we're in farmland in South Central PA, we're using pharmacy spelled with an F, like pharmacy.
yeah.
Catchy kind of term, and the idea is to create healthy food, you know, on the corner streets where our populations need it the most. So that's one opportunity. Second piece that we're working on in terms of a housing insecurity type issue is we have a high amount of lead homes in the city of Lancaster. So we're actually working with the county and just got a federal grant for $10 million to abate lead paint in homes in our city. And there's actually, oh gosh, don't quote me on that, but I feel like the larger number in the county or / region is like 200,000 homes that still have lead paint that need to be mitigated. So a lot of homes from, you know, previous to 1970s that need to be addressed.
So going back to that pharmacy thing, is this the program where a provider gives a prescription for the?
Yes.
I heard that in NPR news.
Yeah, we don't.
Yeah.
We're not quite at that point yet. You know, because I'm responsible still for configuring some of Epic, but I do want to get to that because I think that that's
Yeah,
very intriguing idea, and certainly, you know, Geisinger in our sort of central PA region, just north of us, has been doing food pharmacies for a while as well. So
that's cool.
I
Very
think
cool.
it's
Yeah.
I think it's a good social determinant for us to
Yeah.
really focus on. But you know, one thing I didn't put in, and I actually just showed our board this, because we went through the medical home journey, we started capturing social determinants in terms of, you know, do you have a problems paying or do you have a problem with housing? Do you have a problem paying your utility bill? Do you have a problem with transportation? We actually are collecting those questions based on an Institute of Medicine tool. And we've screened now over 160,000 patients for social determinants. And there's probably about anywhere between 2,800 and 4,200 that have a yes to one of those questions. And so it's enabled us now, it's almost like I said earlier, we risk stratified patients based on their utilization or based on their chronic diseases like diabetes, heart failure, et cetera. But now we can risk stratify them based on their social determinants. So it's really enabled us to now put together programs to say, okay, well, these people who live in these places need these things. How do we do that?
So Dr. Martin, what I see in the community is that the practices are capturing the information, but there is a limitation of resources in the community.
Oh,
So,
yeah,
and so so that how do we battle that? That's like another big why.
Yeah, today we address that in our community through the community health needs assessment. Now, while that's sort of mandated, you know, from the government for us to do a community health needs assessment, it does coalesce our community resources to say, okay, together we're going to work on this. So a good example of that in the last 5-7 years for us is mental health has been a priority for us because of the lack of mental health resources. So we actually ended up partnering with the UHS, the biggest mental health provider in the country, I believe. And they are a joint venture with us on a 126-bed inpatient psychiatry hospital. So that's one way we addressed it.
Yeah.
We have the beauty of having the dollars. I'm watching.
I know, and I'm just sitting here. Some practices don't have that money upfront to invest.
No, I totally agree with you. And I'm blessed as a family doc because up until about 2 years ago, we didn't have counselors in each of our offices. That has totally changed the game for me, both in how we screen for depression and anxiety, because I'm really good at that now. I mean, compared to where I was a decade ago to now, our screening ability for depression and anxiety to not only find people is remarkable, but now, to your point, we're blessed with having the integrated counselors to then refer to them and then, you know, get to have them get the treatment they need.
Right, yeah. It's interesting.
Yeah, thank you for your questions.
So I have one more quick question, and then I'll open it back up. With your size, I'm just kind of curious, your caseload for your case managers, the ratio. I'm just kind of curious what that looks like.
Gosh, you know, that's a really good question, Michael. I don't know if I have the number off the top of my head.
Okay.
I can give you our overall primary care lives is over 200,000. They're divided up into 7 regions. But like I said, we risk stratify those patients. So those ACCT teams, we call them, the ambulatory collaborative care team, they're probably only taking care of, I want to say, 10,000, 12,000 patients apiece. So there's probably 1,000 in each of those teams, 1,000 to 1,500 in each of those teams. But the problem is it's a moving target because some of those people are graduating out of needing help and others are coming in.
Okay.
If I might be able to check one other thing while I'm sitting here in Epic to see if I can get an average number in each of the teams. But that would be my rough guess.
Okay. Are there any other questions out there? I'll take this quick moment to thank everybody for attending. I do want to give everybody just a heads up that we did record this presentation, and we will be editing it, cleaning it up a little bit, and then we will send it to everybody that participated today so that you can share within your organization for folks that weren't able to attend today. Also, my email address is just listed right here. If you have any further questions that you might have for Dr. Rybczynski, please feel free to just email or send me any information, and I can forward that to Dr. Rybczynski and get you an answer or reply from there. We just don't want to bombard his email too much, so please just filter everything through me. Any other questions out there? I know everybody's excited for Halloween, so probably already thinking about that.
That works.
Okay. Anything else? Any closing, Dr. Rybczynski, or final thoughts?
No, that's it. I appreciate everybody hanging in there. I hope it was interesting and you got 1 or 2 pearls to take back. Thanks for your questions.
Appreciate your time. Thank you very much for everybody attending, and we will see you on the next one. Have a good day.
Bye-bye.